Okay, let's start this details of delegation. This is actually going to be a fairly large part of the upcoming exam, so I want to make sure that you guys have a good understanding of what to delegate, when to delegate, how to delegate, and the scope of practice of the individuals that you are most typically going to be delegating to, which in the case of NCLEX world is going to be LPNs and your UAPs or your unlicensed assisted personnel. In your Nursing World Today book, this is covered in Chapter 13 on pages 476 to 484 if you want to turn to that and make sure you're reading that section for a good reference on delegation again, because this is a huge part of both your NCLEX, your HESI, and the upcoming exam you have for this section. So alright, when we talk about delegation, we all know what delegation is. It's that transferring to a competent, there's a key word right there, individual, the authority, and authority is another key word, to perform a selected nursing task in a selected situation. This is actually the definition from the National Councils of State Boards of Nursing. So this is the definition when you think about delegation that I want you to have in your forefront at all times. So you're transferring to a competent individual the authority. You can only transfer or delegate authority, not responsibility. And you're going to see I have that probably on 5 slides coming up because that's a really important point. So when you're thinking about delegation, some of the things you need to take into consideration of what to delegate and to whom is you need to understand the education, knowledge, and skill level of the individual you're going to be delegating to, as well as you truly need to know the job description and the agency policy of whether it's allowed to delegate to that individual, because there are times that technically from the State Board of Nursing it's within the scope of practice, but an individual institution may have an overriding policy that says we don't want you to in that situation. And typically those don't want tos are coming about for a good reason from something that has happened in the past at that agency. But if you don't ask or don't investigate, you'll never know what that type of thing is. So when you're thinking about delegating and how and who to delegate to, there's a couple of tools that you need to think about. You can only delegate tasks that are yours to delegate or that you have responsibility and authority over. Again, like I said, you can only delegate authority. You don't ever delegate the responsibility. The responsibility for that task still remains yours. Again, you have to make sure you understand the state regulations, the job descriptions, and the agency policies of all the individuals involved. And when I have seen lawsuits come out from inappropriate delegation, it typically comes down to agency policy more than it comes down to scope of practice or state regulations. You want to make sure that the individual you are delegating to has actually accepted the delegation. If that individual does not accept the delegation, you cannot delegate the task. Even if you have authority over the individual, you need to figure out a different way to go about that. And sometimes it does involve disciplinary action for the individual who's refusing, but you still need to handle the situation or the task that you are trying to delegate at that point in time. Likewise, or conversely, I should say, on the opposite end of that, if you at all are unsure about your skills or your ability to accept a task and someone's trying to delegate to you, don't accept the task, and be very clear in your words that you are utilizing with that. So when you think about why delegate, because sometimes you'll hear nurses say it's just easier for me to do it myself, then I know it gets done, I know it gets done to my satisfaction. But the bottom line is, in today's healthcare environment, with the amount of skills and tasks and documentation and work overall that needs to be done with these patient care models we have set up with team nursing, it is almost physically impossible for one nurse to do all that is expected of them. So you need to have help, and the system's designed ultimately for you to be delegating to somebody else. But you have to be able to trust those individuals you work with, and sometimes that's the hard part to come by. And we'll talk about some of the barriers a little bit down, but some of the things that potentially prevent you from delegating as a new nurse is that you feel like maybe you shouldn't or you can't. Okay, so some just key points. Tasks need to be within the scope of practice of the person you're delegating to. You as the person who is delegating need to give clear, concise, accurate, and complete directions. You can't just tell somebody to go do something without giving all of those aspects. You need to be very specific about what it is you are wanting and needing done. And likewise, you need to provide ongoing feedback and evaluation of the task that was delegated. You still remain responsible for the task, so you want to understand what's happening, as well as you owe it to the individual to give them feedback as to how they did. Sorry, my tickle is continuing. Things to not delegate. And this is really important to keep in mind. You cannot delegate the aspects of your job to a non-nurse or a nurse of a different level. When I'm saying that, I'm meaning to an LPN, essentially. The aspects that make up the role of a professional nurse. So when you're thinking about this, the easiest way that I know to think about this is through the nursing process. So although there are some assessments that you can delegate to the LPN, you cannot ever, under any circumstance, delegate the initial nursing assessment. Even to another nurse, where that person has the same degree level as you, it is still best for you as the RN taking on that patient to do that initial assessment. You don't delegate nursing diagnoses. You don't delegate interventions that require your professional knowledge and your professional skills. So when you kind of word it like that, the only aspect of the nursing process that you can delegate is some aspects of implementation. So when you're thinking of your ADPI, you can't delegate the assessments, the diagnosis, the planning. Some of the implementation aspects, if they're non-complex and straightforward and do not require advanced degrees or advanced critical thinking, you can delegate those, and you cannot delegate the evaluation of that because that's just another form of assessment. Again, said this before, only authority can be delegated, not responsibility. Tasks must be clearly assigned and continuously clarified. You need to have very clear parameters around how much authority is needed to accomplish that task, and you need to ensure that the task is completed as assigned. Just because you delegated the task doesn't mean you're done with it. It's ultimately your responsibility, because remember, you can't delegate responsibility, to ensure that that task was completed. So just because you might be working with a lazy tech that day and they haven't gotten around to your bed baths or to your vital signs or to your fill in the blank does not mean that ultimately the person who's going to be in trouble at the end of the day is the tech who didn't do the task. As the nurse delegating that task, you continue to hold and maintain the responsibility. So can you see where it's a little bit scary and potentially not comfortable to delegate to people that you may not know well and or you may not trust? And this starts that cycle of why we refuse to delegate, is because I can't delegate the responsibility, only the authority to do the task, but I can't force people to work to my standard. But we need to work through that and have a good team environment, hopefully, where that's not an issue. When you think about delegation, there are a couple of components, and it's very obvious when you think about this. You have the delegate, or the delegator, sorry, let's start there. You have the delegator, who is the individual who is doing the delegation. You have the delegate, who is the individual who the activity is being delegated to. And then you have the task or the activity that needs to be completed. Within the delegation process, you will see this looks similar again to the nursing process, but you have these 5 steps. You need to assess the situation, which identifies the needs of the client. You need to consider the circumstances and the setting in which the situation is occurring, and you need to ensure that you have all the availability of all the resources you need, and that includes appropriate supervision if that's the case. Okay, if that delegated task needs to be supervised, because we need to supervise all of them to a certain aspect. So if you don't have the time to follow up and overall supervise, doesn't mean supervision is kind of a loose word to use, and we talk about this a few steps down. Doesn't mean you necessarily have to be present while the task is being performed, but you have to have enough time to be able to go back and close that loop and to ensure that it was done correctly. Then the next step of the process is planning for the specific task that's going to be delegated. And in this planning aspect, you're specifying the nature of each task and the knowledge and skills that are required to perform that task. You also need to take into considerations the requirement for documentation or demonstration of that current competency by the delegate. So what I'm meaning by this is that when you're making your plan for what you're going to delegate, you need to know if the person you're delegating to is competent in the task you want to delegate to them. So if you think about that for a second, you're going to say, well, hold on, how in the world am I ever going to know all of the different skills that the UAPs I'm working with are competent in? And although I continually tell you don't assume, it seems like in the last few weeks I'm going to continue to tell you, well, here's a time where it's okay to assume. Ultimately, you have to have trust and faith in the organization that you are working within, that if the individual is on the floor, they have received training, they have completed said training, they have appropriately completed all of the different skill competencies that they need to do for their job and have been found to be competent in those skills. So here's where you kind of go back to that loop of knowing your institution's policies and job descriptions, because when we talk about UAPs in a few slides, I'm going to tell you that technically, from the NCLEX world, unlicensed assisted personnel, or your techs, can do bed, baths, and ADLs. And many of you guys are going to tell me that you as a tech can do blood sugars. Blood sugars technically don't fall into that bed, baths, and ADLs. But if at your facility you have done your yearly competency, or actually initial training, let's go back even a step further, during your initial training as a tech, you learned about how to do a blood sugar, you saw a blood sugar done, and then you continued to do 3 under supervision and were checked off for having appropriate technique, you are then deemed competent, and you maintain that competency every year in your skills blitz or your skills competency or whatever your facility calls it, by doing another essentially checkpoint of making sure that you still have good skills. So when you're doing in that planning phase, you have to ultimately think about, is this a task within that scope of practice, and does my facility have good training and skills competencies to maintain the skills for the skills I'm wanting to delegate? And hopefully you can say yes. If not, maybe it's not the best place to be working kind of aspect. The other thing that you need to do, the next step, is assuring that there is appropriate accountability. As the delegator, you accept accountability for the performance of the task. So you need to verify that the delegate accepts the delegation and the accountability for carrying it out correctly. So remember, as a person delegating, you still hold ultimately the responsibility. When you delegate, you need to ensure that the individual you're delegating to has accepted the task. If they don't accept the task, you cannot delegate that task, no matter how much you need to, want to, have to, whatever. If they're refusing, you need to find out why they're refusing. And then if that's an inappropriate refusing, you need to go up the appropriate chain of command on how to report that kind of behavior. Again, the next step now is going to be supervising the performance. And like I said before, it doesn't necessarily mean that you're present 100% of the time. It might on any given circumstance, but it doesn't mean you have to be. But ultimately what this means is you are available enough to understand if the task was done correctly or not. And especially when it is a new tech or a new UAP or someone you've not worked with before, you need to be available readily enough that you can appropriately intervene if it's not being done the way it needs to. And I've actually seen quite a few NCLEX questions on this, where it will essentially ask you if you saw a nursing student or if you saw a tech doing the following, at which point would you intervene, or something along those lines. And it's looking to see if you understand the way the skill should be done and what's within their scope of practice. And then just like anything with the nursing process, you need to evaluate and reassess and overall make sure that things have gotten done the way that they need to be done, and that you provide feedback to the individual. So I alluded earlier that there are some definite barriers to delegation, and I have to say that I'm fairly guilty of many of these myself. Again, as I've kind of described before, I haven't necessarily always worked in an environment where I had people that I could delegate to, but even when I did, I tended to have some trust issues and a do-it-myself attitude. Just easier for me to do it myself and to ensure that it's done the way I want to. Another reason, especially in my younger years as a nurse and even my younger years as a nurse leader, I struggled with delegation, even in my leadership roles. And part of that aspect was the inability to be organized or timely. I was a big fan of the motto that your urgency doesn't become my emergency. And I held true to that even when I was the one in the leadership role. Just because I might be under the gun for a time deadline or not as organized as I wanted to be, I refused to delegate that because ultimately when you're that under the gun and you're that disorganized, you don't even honestly know what you can or can't delegate or what you should or shouldn't delegate. And so it just made it a little bit more challenging for me to do that because I didn't want to impose that level of stress onto anybody else, so I would just try and suffer through it myself. Not always the best way. The other aspect that I kind of alluded earlier is just the feelings of uncertainty, especially as a new grad, and especially if you are a tech on the unit in which you are now working as a nurse. You don't necessarily want to be the nurse that everyone complained about, and you know that there's always those nurses that all the techs complain about, and you might not feel like you really have the right or the authority or the power or the whatever to do that delegation. You do, but you might not feel like you do. There are some environments where the workplace itself just doesn't lend itself very well, because the pace is so fast, you don't have enough staffing, whatever the case may be. And there's actually times, especially in those work environments where potentially the morale is not that good, the delegates refuse. And like we said earlier, if they do not accept the delegation, you cannot delegate the task, no matter how much it's within their scope of practice. Okay, we can't talk about delegation without at least diving a little bit into the differences between accountability and liability, okay? Because there is subtle differences between those, and you need to understand those differences. Accountability occurs when the nurse becomes legally liable for the actions and is answerable for the overall nursing care of the clients that they've been assigned to. So again, this kind of comes down to, as a nurse, you maintain to a certain level, you definitely maintain the responsibility, we talked about that, but to a certain level you maintain the accountability. So then the liability is when you are responsible for your own actions and those that the nurse supervises during the delegation process. So that liability comes in that as the RN, I'm responsible for my own actions, but I'm also ultimately responsible for the actions of the people I've delegated to. Gets a little bit scary there, right? Accountability means I'm accountable for what I've done, but liability means I hold that responsibility for not just what I've done, but what the people below me or that I've delegated to have done as well. So responsibility and authority. Again, can you tell that I want you to understand the difference here, that you can only delegate the responsibility, said that totally backwards, and I'm trying so hard to speak it clearly. You can only delegate the authority to do a task, not the responsibility for that task to be done. So keep that in mind, that you need to be able to delegate appropriately, but you need to make sure at the end of the day the tasks you've delegated have been completed and have been completed to the standard of which they should. So some of the responsibilities of you as the delegator is that you need to be able to identify any action or task that may potentially carry a certain amount of harm, that may be too complex to delegate, or that the patient or the scenario in which the delegation is occurring is too unpredictable. So it could be potentially that the task that you're wanting to delegate in and of itself is not a bad task to delegate, but that particular patient at that particular moment in time is too unpredictable to know how that patient is going to respond, and therefore you should not delegate. So ultimately, don't delegate a very complex skill or task, a skill or task that could potentially harm the patient or the person doing the skill or task, and in a situation where the situation's unpredictable, the patient's response is unpredictable. The delegate's responsibility, so the one who is being delegated to, they have a responsibility to perform the activity at an accepted level. So if I accept the task, I need to do it at the appropriate skill level that is expected of me at my job level. They need to be reliable, they need to be dependable. So ultimately, if they say I'm going to do XYZ, they need to do XYZ. And if for whatever reason they cannot, they need to communicate that in a timely manner. And again, here's just from authority, is the right to instruct others to carry out orders and to use power to expect compliance. So that's when you hold authority. You actually have the right to delegate whatever it is that you are delegating. Okay, so let's talk a little bit, and this is probably repetitious. You can tell that there's a lot of overlap and restating of some of the same aspects. as we've gone through these slides. But the nurse's role in delegation is that you ultimately need to know the rules, you need to know the regulations of the Nurse Practice Act, you need to know the policies of the organization, the job descriptions of the people you are delegating to. You need to assess each client to make sure that it's an appropriate client for the task to be delegated to. You need to ensure that the delegate is competent to perform safely, and you need to be able to supervise that activity. The LPN's role in delegation. And here's where we get into some misunderstanding sometimes about what can an LPN truly do. Especially since the majority of you have never had the opportunity to work with LPNs, especially in the acute care setting, you might not truly have a good understanding of what they can and cannot do. One of the things to keep in mind from an NCLEX question perspective, it truly is all in the words. The nurse needs to initiate plans of care, but the LPN can update them. This is again acute care setting, guys. The nurse needs to complete the initial assessments, but the LPN can do ongoing assessments. The nurse needs to initiate client teaching, but the LPN can reinforce client teaching. And IV administrations ultimately are regulated state by state, but in all states, if the LPN is IV certified, they can start an IV. Okay, some people have a misnomer or misconception on that, where they think LPNs cannot do IVs. They absolutely can. So when we think about that, this is all about the words. RNs initiate, do the initial, they teach. LPNs can update, reassess, ongoing assessments, reinforce, maintain, those types of words. So pay attention, especially in NCLEX questions, what the words are that are being used in those questions. I've got quite a few slides that I'm not going to read to you. I'm not a big fan of reading to y'all. You guys know that by now. But I've got quite a few slides of the PN's role in medication administration. These slides are directly from the National Council for State Boards of Nursing's website. So these are the content or the knowledge or the expectations you're going to be held to on your NCLEX exam. So as you're reading through these, really look through them and see what they're saying. But ultimately, to go big picture on you and to not be reading, PNs have a very active role in medication administration. They absolutely can administer meds. They can do the med calcs. They can alter IV drip rates. They can administer almost every route. Ultimately, at the end of the day, if you have an IV certified LPN, the only thing they cannot do is administer blood and do an IV push. And with the administering blood, the caveat in that one is they can't initiate the blood, and the rationale for that is that that patient is considered to be very complex or at risk for a transfusion reaction in that first 15 to 30 minutes. After that point, once we're past that first initial 15 minutes, the PN can absolutely continue and maintain that, even with the vital signs that need to be taken as frequently as they need to be taken during a blood administration. This again continues on. They can do the IV piggybacks. They can administer drugs by G tubes, NG tubes, buttons, or J tubes. They can do sub-Qs, intradermals, IMs, eye, ear, nose, rectum. Pretty much any route they can administer the medication. They can count narcotics, they can count controlled substances, they can regulate IV rates, they can monitor, here we go, monitor transfusion. They don't initiate, they can monitor ongoing. And same with IV sites and flow rates. So now let's get to the UAPs. These are your techs, your certified nurse assistants, your techs, your UAPs. You'll see all of those terms used interchangeably. I will tell you from the NCLEX world, most commonly you're going to see this as UAP, unlicensed assisted personnel or assistive personnel. Best way I can tell you guys, they can do bed baths and ADLs. They have no license, so truly they are uncertified in that aspect. Also means that technically speaking, from a professional perspective, they have no scope of practice because they have no license. So when you're trying to decide what can or can't my UAP do, ultimately what they can do, bed baths and ADLs, and obtain data. What do I mean by obtain data? They can get the set of vital signs. They can tell you how much urine was in the Foley, but they can do absolutely no assessment or interpretation of any of the data that they obtained. So like with the blood sugar, they can absolutely get the blood sugar. They can do nothing with those results other than document them and tell you as the nurse. So when you're trying to make those decisions, keep that in the back of your mind because sometimes it gets confusing. And I will tell you guys, those of you who have the experience of working as a tech, please throw out everything you know from your own tech experience when you are answering these delegation questions, because it's only going to muddy the waters and confuse you at the end of the day. Try as hard as you can to keep this as clear cut as possible, knowing that I'm asking you to do something that's truly not very clear cut in any way, shape, or form. Disadvantages to delegation is when it's not done well, obviously, right? Ineffective delegation, like the tasks are not completed, or they're completed incorrectly. Delegating too much authority or responsibility to the team members under delegation is a problem, actually, where you as a delegator don't think your team members can handle it or that they're going to do it well, so you just hold on to everything and don't delegate anything. You're going to get overwhelmed. It affects the morale of the unit. It can affect the teamwork dynamics. Reverse delegation is an interesting concept you might not have ever heard about, but ultimately reverse delegation is when a team member requests that the nurse leader, so on the instance of a floor, it doesn't have to be they're asking the clinical director, they just might be asking the charge nurse or the team lead to do a task that's been delegated to them. That's reverse delegation. Typically when you see the words reverse delegation, it's used negatively. There are times when it is absolutely okay, and not just okay, but necessary based on the environment of the unit and the crisis of the moment kind of situation. And the other problem, and I'm sure you guys know nurses like this who over-delegate. They delegate their entire job away and they sit at the desk, right? They're going to put up their feet and eat their bonbons kind of aspect. That's definitely a disadvantage or a problem within delegation. And it also leaves an ugly taste in people's mouths when they're trying to appropriately delegate, because you get burned by those individuals who over-delegate. 5 rights. Without a doubt, you need to know these. You should be able to tell me these off the top of your head without hardly blinking an eye or having a thought about it. The 5 rights to delegation is the right task, the right circumstance, the right person, the right direction, and the right supervision. Okay, so you've got the right task, one that is delegatable for a specific client. You've got the right circumstance, meaning that there's an appropriate client setting. You have all the available resources, and any other relevant factors are considered, like essentially it's a stable environment or a predictable environment. You have the right person. And right person, actually, when I read this statement to you, it gets a little confounded, but it kind of makes sense if you stop and think about it. The right person is delegating the right task to the right person to be performed on the right person. How many times can we say right person, right? So essentially, the right person's doing the delegation to the right person on the right person. So you've got the right nurse delegating to the right UAP on the right patient. That's what we mean by right person. And you've got the right direction or communication, which ultimately means we are giving clear, concise description of the task, including its objectives, the limits, and the expectations. And we've got the right supervision, meaning that we've got the appropriate monitoring, evaluation, and intervention as needed, and of course that we are providing feedback when all is said and done. And because there's really no other easy place to put prioritization tips when you're having to prioritize which patient to see first kind of aspect, I threw it at the end here of delegation, because I always talk about prioritization and delegation in one fell swoop. Again, just as delegation is a very large part of your NCLEX exam, so will be prioritization. So some tips to keep in mind when you are trying to decide which patient to see first. Acute will always win over chronic. So if I have a patient who has COPD, a patient with CHF, and a patient with appendicitis, I don't care how sick they try and make the CHF patient or COPD patient, unless they're actively dying, like truly in the process of actively dying, you see the appendicitis patient first, because the other two situations are chronic situations. Your fresh post-ops are always going to trump your medical issues or other symptoms that you have going on. And some of the things to think about with fresh post-ops, it is typically general anesthesia versus local, a post-op who's less than 12 hours, a patient who is admitted less than 24 hours. Those types of things are going to trump the other aspects. Keep in mind the general versus local anesthetic, because I've seen a lot of different NCLEX style questions try and trip students up with that, where it might be somebody who's had a breast biopsy an hour ago, so they seem like they're the newest patient, but it was a breast biopsy, and breast biopsies are typically done under local anesthetic. And then the other patient that they want you to go see first is like a cabbage that's 8 hours post or 12 hours post. But that cabbage was actually a fairly intense, complex surgery, and definitely under general anesthetic. So that's going to trump your just even immediate post-op or post-procedure is really the best way to say that, breast biopsy. Stable versus unstable. And so we've kind of talked a little bit about the unstable or acute is your post-op less than 12 hours, your newly admitted patients. And again, I've seen this happen many a times with the newly admitted patient. It might make it sound like the patient's fairly stable, but they're the newest patient on the unit. So a lot of times it'll read something along the lines that a new patient who's not been seen from the emergency room comes up to the floor, but there's another patient who's complaining about something. Your priority becomes seeing that new patient who's been admitted to the floor, because even if the question makes it sound like they are stable, if they are sick enough to be admitted and not sent home from the emergency room, they're sick enough to be seen, even if they have no active complaints at that point in time, and that becomes your priority because you don't have your initial assessment or any kind of baseline data on them from since the time they've hit your unit. And the thing to keep in mind with NCLEX style questions, and both true on the NCLEX and the HESI exam, is that the test writers do a really good job of trying to make something that is truly unstable sound stable. So in your head, try and paint a clinical picture of what this person would look like in front of you. Because I guarantee if I took you up and down the hallway and showed you each of these patients, you would most likely make the correct decision. But with the way those things get translated into words, sometimes trip you up. So try really hard to paint a picture. As a very, very last resort, and I almost hesitate to say this because it is truly a last resort, when you have nothing else to go by and you're trying to prioritize the level of care or the care that you need to be given to which patient, you can sometimes use level of organ. So what I mean is that lung issues will trump heart issues, which will trump brain issues, which will trump kidney, which will trump liver. And you can argue with me a little bit if you'd like, but I kind of, over the years of teaching this, have decided that I like this order the best. And when you want to argue with me, sometimes you want to argue with me between lung and heart, but the bottom line is if I don't have oxygenated blood, it doesn't matter how well my heart is pumping. Again, I'm certain we can all come up with situations when potentially that's not the case. But if you're using this as a tiebreaker kind of situation, you can typically go with that. So this is just a few little tips. We're going to have some practice questions. We've done some practice questions in SIM, and we'll continue to work on them in open office hours and such, because this is going to be a large part of your exam. So if you have questions, don't hesitate to let me know.